All right, good morning. Disclaimer, the title is super corny, and I'll let you know how it came about. So I was working on this, and I've got a couple of good girlfriends that are also entrepreneurs, and so we have work dates. We go sit at Boston Pizza and work, and they don't bother us, and it's great. And so I was like, I gotta come up with a title for this, and they're like, there's only one obvious title. It's To Be or Not To Be. And I was like, oh, come on, guys. So then that's how that sort of came about, and we laughed about it, and I apologize for the terrible joke. Yeah, okay, so thanks for the introduction. Thank you for having me out here. It was really exciting, actually. I met Brad through, I guess, sort of through chiropractic, but then we sort of got started with the Friends of Lower Fort Garry, and now we know each other through both ways. And it's nice to delve back into immunology. It's my first love, I guess you could say, and so it's nice to get back into that and study out and look through all this stuff. And I didn't really know much about bees, so this was like, yes, let's learn about it. So it was really cool. So just to get started, who am I? So I was introduced pretty well there, so I'm not going to spend a lot of time on this, but I've spent a good chunk of my life studying in school, and my father is very grateful that I finally graduated. And I'm starting to pay back those student loans to him that he co-signed. So yeah. But just a little bit about me. So one of the things that I love to do is I actually love history, and I love to animate at Lower Fort Garry. So I worked there for many years as a historical interpreter, and now I'm with the Volunteer Association, so I'm in costume throughout the summer. I also love the Winnipeg Blue Bombers. So luckily my research actually with inflammatory bowel disease has gotten me to know Abi Khan pretty well, because he also has colitis. And so we've met each other at a few events. So whenever I'm at the games, I try to track him down at a shawarma Khan stand. I love to be outdoors, and this past year I got to go back to Narcisse, and that was fun too with the snakes. And then the obligatory cute child poster, this is my nephew. So I had to put him up there because he's just adorable, and we decided to dress up in German costumes together. So yeah. So that's a little bit about me and me personally. So you get an idea of who I am. So really just to talk a little bit about bees and get onto the subject that we want to talk about today. So the order Hymenoptera includes ants, bees, hornets, and wasps, and that's sort of where we're focusing today. And many of these sting, but as we learned, a lot of them have different levels of aggression, and the amount of venom injected also varies between them. And then how our bodies respond to those types of venom varies between them. Now, bees usually sting defensively when their hive is thought to be under attack. And when they do that, they deploy the stinger from its sheath. And with that comes a chemical like pheromone that actually has a banana type smell. So if you've ever been stung and you sort of smell bananas, the pheromone has that type of smell, and it's released, and you might hear a short buzz when they do that. And what you'll actually notice is that banana pheromone actually attracts other bees. Now, approximately 25% of the stings in the US are from honeybees alone. So they have quite an involvement in giving us the responses. Now, the honeybee sting itself has a barb, which leaves it attached to the skin, to its victim there, and it has the venom sac with that. And the sting apparatus is actually covered by a muscle, and the muscle will continue to pump so that it pumps that venom in really well. About 90% of the venom is emptied in the first 20 seconds, and like I said, the victim is then marked with a pheromone that recruits other bees. So it's sort of this exponential thing, like, oh, I'm getting attacked, everyone come and help me. So each venom contains about 140, sac contains about 140 micrograms, and about 50 micrograms is injected into the victim. And it contains many different types of chemicals, and a lot of them are the potent ones that cause the reactions, and this is how your body reacts to it. It's all these different chemicals it's injecting. So the two main ones that we want to talk about with honeybees that are unique to honeybees are melittin and apatin. So in about 40 to 50% of the venom sac is melittin, and this is a cytolytic chemical. So it's a chemical that breaks apart, bursts the cells of your body, so it actually breaks them down, and this is what's causing that sort of reaction where you get that itching and that swelling after a sting. Now, the other one that we talk about is apirin, and it's only about 3%, but it is the neurotoxin, so it actually directly involves the nerve conduction, and so that's where you're getting that pain signal from it. Another contributor is called mast cell degranulating peptide, and we'll learn a little bit more about mast cells when I delve more into the immunology side of this, but this breaks down these mast cells, and that allows them to release these granules, which is then where you get that greater allergic reaction following the injection. So all the proteins and enzymes in the venom work together to cause a reaction, so that's where you get your pain, your swelling, your itching, the redness, the general sort of response you get when you get stung. Now these proteins can also be recognized as foreign by the human body, and then that's where you're going to start getting this allergic response in some individuals. So what are some of the responses that we can get to honeybee venom? Well, the normal reaction, okay, is just one of local pain. You have a few centimeters of swelling, which is called a wheal, just that little bit of swelling right there, and then maybe a bit of redness that can resolve. And usually it's in a few hours to a few days, it feels a bit better. It can be uncomfortable, but it's nothing really, really bad. It's tolerable. And then usually you treat that with ice, lotions, some baking soda that will neutralize the acidity of the venom, and some pastes. And you can find these things on the internet, what works with people to draw out the venom. So this is a really general reaction. Sometimes people get a more large local reaction. So here what happens is you get that area of sting, but within the 24 to 48 hour period, it expands significantly, but still stays in that area of the sting. So if it was on your leg, it would stay within the leg, but it'd be a lot bigger as time went on. It's usually very itchy, and really the best way to treat this is just ice on antihistamines, and same thing, just sort of wait it out. There's not much you can do about it. Now the one that we really want to talk about today, and the one that a lot of people are like, oh, bee stings and allergies and all that sort of stuff, is what's called the anaphylaxis or systemic allergic response. Though these involve, when we have anaphylaxis, you're involving 2 or more systems of the body. So where the other ones really just involve the skin, this is involving other systems within the body. So we can have gastrointestinal, we can have nervous, and then we can have the cardiorespiratory system. Now the skin response is usually not only at the site of the sting, it's also far away. So you might get stung on the leg or the arm, but then you'll start to get responses throughout the body, swelling in the lips, swelling on the hands, swelling on the feet, like all this different stuff. It travels really fast. Then the gastrointestinal response includes nausea, vomiting, diarrhea, abdominal cramps, things like that may start to come up. Neurological will include dizziness or lightheadedness, you might feel that. And then the last one, the cardiorespiratory, is the one that we're most concerned about and is the most dangerous. And that's wheezing, the inability to breathe, your blood pressure drops really fast, and you can lose consciousness. Now these occur very, very quickly, and they can be very deadly. And the responses to these is immediate emergency care. So you have EpiPens or you have epinephrine. In the EpiPens, you administer that, you take them to the hospital. That's the best way to do that. So what the question really comes down to is, why is it that some people get this response and some people end up like this? Like where is this going on? And there's a lot of studies and looking into this, because immunology, as much as we like to say we studied it for a long time, which we have, there still is no clear answer. Every body is different, everybody responds differently, and so it's making it really difficult to sort of figure out exactly what the one clear answer is. But there are some good theories behind it. So let's look back and let's go look at the immune system. So, the immune system. So the term immunity is derived from the Latin immutatus, meaning exempt. And classical immunology studies actually date back to 430 BC. So we've been studying immunity for a very, very, very long time, because people, the big scientist historian Thucydides, noticed that people who were sick and then recovered from the disease could nurse the sick and not get sick again. And so here are people who've already encountered it, and now all of a sudden nothing's bothering them again. So it was sort of the study that they wanted to look through, and since that time we've been, especially now with modern instruments and medicine and things, we can really start to delve into the cellular level and see what's going on. So to function properly, an immune system must detect a wide variety of antigens, okay? And these are agents like viruses, bacteria, parasites, worms, and distinguish them from your body's own healthy tissue. So it needs to know what's self and what's non-self. Now, protective immunity is mediated by the early reaction of the innate immunity and then the later responses of the adaptive immunity. So immediately when we encounter things, we have our innate immunity. That's right there, it's built into us. The skin is part of your innate immunity. We have that barrier so microbes can't even get in. If that's broken down, then we have a couple of quick ones that start from there. So we have phagocytes, which are cells that eat, and dendritic cells, and then we have natural killer cells, that's NK cells, and these are all different types of cells that have different chemical mediators that go out and, kill the things that come in, okay? Now, unfortunately, what happens is once it actually breaks that skin or that epithelial barrier, it starts this process. So, we look at 3 lines of defense. So like we talked about, there's that first line of defense, the skin, mucous membranes. They're a very protective barrier, they're also a chemical barrier. So actually your skin has a pH level that inhibits a lot of microorganisms from growing on it. The mucus in your nose, in your mouth, also same type of thing, right? The body's well designed to kill anything that's coming in that way. Once something actually, penetrates that first line of defense, like a bee sting, okay, we get into the second line of defense here, and that's the phagocytic cells. So cells that are damaged then, so when something's like damaged it, literally physically damaged it, they release a signal. These signals then attract other cells called neutrophils, macrophages, and these types of cells destroy that damaged tissue. Then they come in there right away and they say, okay, something's wrong, we need to get rid of this because there's something wrong with this tissue. This results in your immune response when you think of something. So swelling, redness, pain, all that stuff is these cells coming in. Now, we always think of that as a bad thing. It's not a bad thing, okay? We want this reaction to happen because this is what keeps us alive when bad things enter our body, okay? And so what it's trying to do is it's trying to destroy this attack. So if it's a bacteria or a virus, right, you're trying to destroy those things, those microbes. If it's a bee sting, it's trying to destroy any of the cells that have been injected or damaged by this venom so it doesn't spread exponentially. Now the second line of attack then brings in the third line because these cells then play a role of an antigen presenting cell, which means they'll take in whatever that foreign item is and they'll break it down, and then what they'll do is they'll present it on itself. This then brings in what's called your lymphocytes, which is the third line, and that's B cells and T cells. And you've heard of B cells and T cells, you just probably haven't heard of them spoken of that way. They really bring the specificity to the war, okay? So they are very direct to what is bothering you. So it was prior to this, it was more like a blanket protection, like, oh, something's invading me, I'm just gonna try to attack it or I'm gonna keep it out. This is more like, what specifically is attacking me? Let's go find that type of problem and kill it, wherever it is throughout the body. So T cells work to alert the body to the non-self molecule. So they'll recognize this little presentation right here, and they'll specifically go find the body and control the immune system to come in and find that specific spot again. So this type of presentation, this type of antigen on here, or presenting antigen, is on anything that's foreign in your body too. So when an antigen comes in, it'll have this built into it. So if we can get the body to recognize this, it will know to attack any cell that has this naturally in it. And that's really how immunity works. So T cells go in there and they try to recognize that. They can process, they bind to it, they process that cell too, and they say, okay, this is what we don't want. And they can either kill it directly, there's different types of T cells. They can either kill it directly, or they can bring in the next set, which you probably know, which is B cells, also known as antibodies. Okay? So antibodies are very, very specialized. They're very, very specific. And they will stay in your system too. So there's memory antibodies that's why if we get inoculated or vaccinated, we'll keep those antibodies. And then if we encounter it again, the body will just ramp up that system and kill it before you really even notice you're getting sick. It's really cool. And what they do is they have a process on their cell. They have an area of it called immunoglobulins. And these have a region that are very specific. And there's different types of immunoglobulins to respond to different types of infections. So we have the IgM, which is our immediate response. They are produced very, very quickly and they'll attack. And then as time goes on, a couple of hours, you start producing IgG. So Ig stands for immunoglobulin. These ones then produce the normal attack. When you think of you're getting sick and you think of what's helping you and healing you and stuff like that, it's IgG. That is our main antibody out there. Now, one type of antibody that we're going to really focus on today is IgE. IgE is the one that's associated with parasites and now immune and allergic responses. Okay, so before I continue on, does anyone have any questions on this? Because I know this is like, there's so many different parts and it's super confusing. You're back and forth through books when you study this. Okay, so IgE is our big one that we talk about with parasites, and we'll come back to that. But the other thing that is great about the immune system is it actually has self-tolerance. So our immune systems have a check system to ensure that we aren't reacting to our own cells, right? Like, so how does the body know, like, oh, that's my regular skin cell, or that's, just a piece of peanut in my body, and that's not something I should be reacting to? Well, tolerance to self-antigens is fundamental to this. And during maturation, so while the T cells mature, if they recognize everything really, really highly, so there's this type of binding specificity that binds with it, if they're really, really strong, the body gets rid of it automatically. The body says, no, you're just binding to everything and we don't want that, and they kill it. That's literally it. So it's a self-check system. So that's immunological tolerance. Several factors favor this tolerance. The dose of what you're getting. So if you're getting a lot of something, they're going to say, okay, this is probably normal within the body. The repeated exposure, if you're getting exposed to it regularly, how you get it, so if it's intravenous, the blood, or the orally, or anything like that, and the presentation by the cell. So say, like, if it's bound really, really tightly, then the body's like, something's wrong. So when it doesn't respond to it, that's immunological tolerance, right, and unresponsiveness to an antigen that is induced by exposure. So that's normal. Problem is that doesn't always happen. Sometimes the immune system loses tolerance for itself and turns against molecules of the body. So it mounts an abnormal immune response to self. So in an autoimmune disorder, the immune system cannot tell the difference between self and non-self. Okay, so what's foreign and what isn't and what's invading. And this becomes actually a little bit dangerous because it produces then this self-reactive antibodies, and you start to attack your own cells that you would normally ignore. Now, when you have an allergic response to something, what happens is you have your IgG antibodies that we talked about here that come from your B cells. Okay, so your allergen or your antigen, same idea, produces these B cells and the T cells, and the B cells specifically go to IgE. Now, IgE, the antibodies, then attach to your mast cells. So when they get activated and they find this antigen, this allergen that they can't have, they attach to your mast cells. And then they release a whole bunch of these granules. These granules have a lot of chemicals in them. Now, the cells that are recruited by the body to make these E cells literally differ with people in even the response to the same foreign antigen. So I could be injected with something, you could be injected with something, and our bodies will respond differently. And so this leaves some individuals to create these IgEs and have this crazy allergic cascade, whereas in someone else, they might just get a little itchy red spot. And unfortunately, that's where science is right now going, why? Why is it different person to person? Is there something that's different in people that are causing them to respond? So the mast cells are loaded, so back to that. So the mast cells are loaded with granules, and the granules create a lot of different chemicals. So they have cytokines, which bring in other types of cells to respond to it. They have histamine, so you've probably all heard of antihistamine, to take antihistamine if you have an allergic reaction or something. And histamine causes a lot of the swelling of the skin, and it causes the irritation, and it doesn't go just to the skin, it actually goes to the airways too, and that's where you start to have that real problem when your throat swells up and you can't breathe. It also releases proteases, which break down the proteins of the body, other chemicals that bring in other cells, and especially allergic cells called eosinophils. And all of these cells come in, and what it is like I said, it's a cascade. This brings in this, which brings in this, which brings in this, and then all of a sudden you're getting all of this response, and your body is overwhelmed with this crazy response. So if it does take in the whole body, and if it does start to overwhelm, that's where we call it anaphylaxis. So, we probably have heard in the last, little bit how much allergies have increased in the last 50 years, and it's actually quite true. So if we look at this graph, I mean, it's a little outdated, but it's still very, very relevant. You'll notice that in the last 50 years, mumps, measles, tuberculosis, all of this has gone down significantly. And things like smallpox is almost eradicated, and this is all thanks to vaccines. They've done a great job in helping clear us of infectious diseases. And changing how things are how modern medicine is working. However, we'll notice that in the last 50 years, autoimmune disorders have increased. So asthma, Crohn's disease, multiple sclerosis, type 1 diabetes, all of these things have increased, whereas the others have decreased. So pretty much they have mirror imaged each other. Now, the prevailing theory as to why this is happening is called the hygiene hypothesis. And the reason for that is we live in a world here in Canada, the US, it's very, very clean. We don't encounter a lot of parasites. We don't encounter a lot of worms anymore like they used to. And so our body is not fighting as much as it used to when it was younger, when you're children. And so it's not developing and using these antibodies as it's been designed to do. And so now that we live in this parasite-free world, pretty much, a part of the system can run rampant because it doesn't know, and it thinks, oh, maybe I'm supposed to be doing something because something it's not being encountered with the stuff it's supposed to. And that's where IgE comes in. IgE antibodies are supposed to fight against parasite, worms, all that sort of odd stuff that you would have had if your food wasn't clean, if you didn't have clean bathrooms, and you're encountering all these crazy things that come out. So we don't have that anymore, so the IgE response is now responding to that. And this is where the theory comes from, that this hygiene hypothesis is occurring in developed countries. Now, this is the prevailing theory. Although recent studies, as I was going through with bees and bee stings, is actually quite interesting what IgA might be evolving into being used for. So, in 2013, researchers in California explored the reaction of mice to honeybee venom. Okay? So in group 1, they injected a dose of venom, about 1 or 2 bee stings worth, into mice in group 1, and then they left the second one as control, so they didn't give them anything. And then those mice that got injected showed an IgE response. So IgE ramps up, protects them, they get sick, but then they get better. Okay, so we have this increase, but the group 2, of course, no injection, nothing changed. They're just living their life, moving around in the cages. Okay, now, then, following that, 3 weeks later, they give both groups a lethal dose of bee venom. And what they found is those in the group 1 that had already been stung and had a response, 86% of them survived. But the group that had not been stung, only 7% of them survived. This is a huge difference. So the scientists saw a very similar effect, though, when they repeated this experiment using snake venom. So same thing, venom, which contains very similar allergens to bee venom. The antibodies still protected the rodents when they did it. So then they looked into it further in a different study that said that injecting mice that didn't have IgE, okay, so that you can breed mice with certain traits. So they bred mice without IgE, and then they injected them with this venom-specific IgE blood. So then they put the IgE back in them, and then they gave them the dose, and they repeated the experiment. Those that didn't have IgE died, and those that didn't had a protective effect. Those that got the IgE blood had a protective effect. So we're looking at this going, okay, well, maybe IgE is doing something that is needed. And then in another experiment in Yale, I was looking through these, confirmed that the experiment showing that mice with a previous IgE response to bee venom have a greater resistance to potentially lethal doses later on. So, and what they really started to conclude was those that lack IgE miss out on this protective effect that it offers. And this is the first real direct evidence that IgE-mediated responses can be protective. And this supports the hypothesis that IgA, which also contributes to allergic disorders, has an important function and perhaps has evolved to protect us from toxins. Now, if we look at beekeepers specifically, and I assume this is how you guys are every day.
Yeah.
Yeah. Okay, good. Yeah, because you're cool with bees.
We have a glee club, so.
Yeah. You guys have a band, I hope. So when we look at beekeepers specifically, compared to the general population, beekeepers have a higher prevalence of allergies. So 42% of beekeepers actually have allergies to bees. And it's like, what causes this? It's an occupational hazard, you can say. So what's causing this? Why are you getting this higher response? So there's a bit of a unique look at this, because they're not really sure why that beekeepers themselves are getting a higher response, except for the fact that you're literally around it all the time. So your system is already sort of ramped up, and you're getting this toxin all the time. But at the same time, you're more likely to build up immunological tolerance to it because you're around it so often. So once again, researchers, in 2013, determined some risk factors. So if you've been in beekeeping less than 10 years, you have less than 4 stings a month, and you have a family history of responses, you're more likely to have an allergy to it. Right? But it seemed that sensitization occurred, and that exposure over 20 years in persons over 50 years of age actually had a protection of it. So the longer that you're in beekeeping, you're like building this protection to the toxins in it. So it's very interesting. So when they were looking at beekeepers, they found that those faced with daily stings in their work are, perhaps less prone to deadly or allergic reactions. They still respond more, but they're not doing to the full extent of anaphylaxis and deadly reactions. So you're sort of trading off one for the other, right? So whereas I don't beekeep and I may not respond as strong as you, if I get stung, I might respond and die. right? So you're sort of getting that, oh, it might be a little bit worse, but it's not full blown because your body's tamping it down. The University of Switzerland had a study where high doses of bee venom early in the year block a normally potent immune reaction, so an oversting, in the remainder of the season. At the beginning of the season, beekeepers showed visible signs of an immune response. So like first couple of weeks, you get that sting, you get that inflammation, you get that wheal, swelling pain, and then within a week, the immune system sort of adapts to it, everything drops down, and you're good to go. And this lasts for about a year, and then the next season, same thing. Right at the beginning, you're gonna get that reaction. So you can better tolerate a stronger dose than someone like me who's not around bees regularly could. So what is the sort of secret that keeps you guys safe, okay? What keeps the keepers safe, as we like to say? Well, the production of regulatory T cells. So we talked about T cells already, compared to the B cells, right, the antibodies. Well, the T cells actually play a role in regulating the immune system. And so the first bee attack triggers the production of histamine. And this is a chemical that drives that allergic reaction. It gets that swelling, that itching, everything is gone. And the beekeeper then if he's stung again, he or she is stung again, then this is going to keep going. But at this point, a T-reg comes in, a regulatory T cell comes in and says, whoa, something's going on. There's too much histamine. There's too much reaction going on. And they morph and calm down the immune response. They say, no, we don't need this. And they come in and they calm it down. And then they last throughout the year. They stay there because you're going to continuously keep activating them if you get stung. And we're going to go in there, they're going to do that. They're also going to decrease your IgE levels. And so you're going to drop that so you're not having that response again too. So it works sort of within the body, sort of made this own little way to come in and say, okay, wait, stop. This is going to happen to us, but we know it's okay. We can keep it under control if you keep having exposure to it. So one of the things that started is because of this and because of these anaphylaxis, like what do? There's beekeepers who are like, well, I want to keep beekeeping, but I'm scared. I've had this before. What's going to happen? One of the treatments that's come out now is called immunotherapy or desensitization therapy. And so people that are so allergic, they benefit from controlled injections of a very purified bee venom. So the goal of it is repeated exposure to the venom leads to a change in the way that the regulatory T cells in the immune system react to the particular offending antigen. Literally what happens to you guys. If you get stung a little more regularly, the regulatory T cells come up and they protect you. Well, that's what they're doing for people who have anaphylactic responses, and they keep them up. So the T cells instruct the B cells to switch from IgE to IgG, so it's non-allergic, so then you're not getting that allergic response. And what you're seeing is that, just like the allergic beekeepers, that the bee-specific venom is sort of keeping that down in there. So what happened what they did is a couple of studies, and they found that after 5 years, they found a markedly decreased risk of anaphylaxis. So after therapy had been undertaken, the risk was about 10% to go back into a whole systemic immune allergic response. And if you didn't have it, it's about 50 to 60%. So you had quite a change in protection to the venom. So how does it work? Well, in essence, what happens is typically it's a 3-month program at the beginning, and you get weekly injections. You start with very, very minute injections, very small, pure stuff. You have a little bit of a histamic response to it. So you take a little antihistamine, put a little ice on it, you just deal with it. You always, if you have allergies, do this in your doctor's office. Do not do this at home, okay? Clarification. So you're gonna go to your allergist, you're gonna deal with this, they're gonna have this, they're gonna watch you, they're gonna make sure they have everything on hand if something goes wrong. Because this isn't a foolproof thing, not everyone responds positively to this, but it's pretty good. So they get you this tiny amount, and then what happens is weekly they increase it slowly, and then by the 12-week mark, you're having about the dose of 2 bee stings at a time, okay? And at this point, you switch over to a maintenance program, and for about 3 to 5 years, you get a monthly dose. And it's worked quite well. So, yeah. So, looking at this, you're seeing how beekeepers can respond to the bees, but they also can provide that protective barrier to them. And so I think what we're really trying to learn from this is it's sort of that general exposure, and you sort of make tolerance for yourself by being there. Now, saying that, some people still have an allergic reaction, and if that's the case, very, very importantly, that you get yourself to the emergency room, okay? Don't start putting things on it, get over there, get injected epinephrine, and then you can talk to your allergist about what to do is in treatment. So seek an allergist. The big recommendation is really you give up beekeeping temporarily while you do this treatment. Very short period of time, you give it up, you do this treatment, and then you come back to it, and then we're usually good to go. That seems to be the big plus here. But always wear productive clothing, always have your EpiPen nearby, always let people know where you are so that if you do happen to pass out, they know that you're not just gone somewhere, and they know that something's wrong. And keep your cell phone near you. And that's the biggest thing. But that's about it. So these are the papers that I used for all of you who want to search on your own. I can give you a list. But do you have any questions?
Dose again. What's going on there?
It could be a combination of, like I said, it doesn't work for everyone, unfortunately. Some people have a very, very responsive immune system, and this immunotherapy just might not work for her. She might just have that really, really strong sort of IgE response that just is not going down. She might have the Tregs that aren't being produced as they're supposed to be in the situation. It's really, really difficult because every person responds so differently to these things. And unfortunately, like I have a really severe peanut allergy, okay? So if I touch, smell, eat a peanut, I'm done. The immunotherapy didn't work for me either. It's so severe that it's just not, my body's just not gonna respond to it.
She's coming along.
She gets up there, and it's that threshold, right? She hits that threshold and the body just can't take it. And that's probably where it is. It's probably about the same time that it always sort of drops back. She has to drop back down and go up again. It's probably about the same level. Yeah, it's probably about the same level, and it's just that sort of threshold. Now, it might also be that she just needs a little bit, and she just needs to take it slower. And so they might just keep going, and it's just a slower tolerance build. Yeah.
Mine is more of a comment, but with a question at the end. Somewhere about 1980, 81, in the spring, when we used to bring packages in from the States and install them in the hive and then kill them in the fall. One spring I started getting really bad reactions, a couple of trips to the hospital, and epinephrine, antihistamines and so on. The doctor said, well, you've had a few things this year, just be careful, but I'll refer you. So it was referred to Dr. Warrington at Allergic Clinic at Health Sciences.
Yes, he's awesome.
I went through desensitization. You know, it was a big hassle, about 2.5 hour drive into the city every time for all those shots. Then I get the purified bee venom, once a month. And eventually I said to him, well, what if I just get stung? And so for the last almost 40 years, I go in the summer, it all happens automatically. In the winter, I go in the bee shed and put a couple of bees on my arm and get stung. I've been a little lax this year, so it's almost 2 months since I've had my last stings. But I don't know if I need to keep that up, but it became a routine. And in the summer, even if I have 30 stings in a day, I don't have an adverse reaction, hardly at all. Like just local swelling, no systemic reactions. Yeah. We've got a daughter who at age about 8 had a really bad reaction, went to adult, Dr. Simon's at Children's Hospital, went through desensitization. The first thing a couple years later was no problem. One after that, another really close call. So she's got her EpiPen always with her.
And she's not getting regular stings like you are.
She's not getting regular stings like I am. And she's thinking about, should she go through it again? If she comes to our place in the summer, we leave our garage door open. She drives her car right in and just comes in the house. She doesn't go outdoors but she'd like to garden with us and things like that. So I don't know if you have any comments. Like obviously in my case, it was very successful.
Yeah, and you're literally proving exactly what the research is showing, right? Yeah. Like that regular sting is keeping that huge reaction down.
Yeah. Anyway, that's it.
Yeah, so I think the best would be to get your daughter back through that therapeutic. Don't just take her for a sting, because it's been a while since she's been stung, right? So make sure she gets back into that immunotherapy, and then she probably, just a regular sting would probably keep that tolerance and keep her safe. So yeah, then she could garden with you regularly.
It's probably more than 20 years since she had the last reaction, and as I say, she carries an EpiPen, all that. She hasn't had to use it, and we've got other allergies in the family.
Has she been tested in the last 20 years?
She's going back.
Okay, good. Has she had kids in the last 20 years?
Yeah, she's got 3 kids, and they get peanut allergy.
So allergies do run in the family, but it is a genetic thing. Get her to get tested, because they've also known to go away once you've had kids, because your hormones change and they can change how your system reacts to things.
A number of years after Dr. Warren's office, I was tested, and they talked about something about teeters, and I don't know what that means.
Oh, so
yeah, you're still allergic because your teeters are such.
Yeah. So the Ig levels in your body, okay, that's the titer. That's the amount. It's literally just the amount. It's a unit of measurement. So if you have high levels of IgE, you're more likely to be reactive. Yeah.
So you said you're still reactive, still get stung.
Yep. I say keep up. It's been working for you just fine. And it's a natural way of doing it and saves you 2.5 hours every month.
Well, I'm closer to the city now, but it's still
Yeah.
easier.
I just want to congratulate you on an excellent talk.
Oh, thank you.
I'd also like to ask you if there's any other correlations with other allergies and bees. And I'll just give you a bit of a reference. I work with a lot of people that I help them get started in beekeeping, and I'm often the person that I get called a couple of years later saying beekeeping is no longer fun because I seem to be reacting more and more. And sometimes we have conversations and it seems like if they have other allergies, it seems like after 2 or 3 years, that sting that they get on their finger swells all the way up to their shoulder. So it's not anaphylaxis, it's just a more severe...
It's that large local reaction.
Yeah.
Yeah. Yes. So, like I was saying with the titers with the IgE, the IgE is that immune response. And if you're allergic to other things, you're going to have more IgE in your body, and it will react. There is a likelihood that you'll react to other things as well. So it does increase your chance of being allergic to other natural, non-noxious substances, like just normal things. So that probably is why. They still might respond well to an immunotherapy type response and be able to keep up beekeeping and keep that sensitization in there.
Usually my response is if they want to stay beekeeping, they should get tested because it could get.
Yes, they should definitely get tested. And the biggest thing, honestly, is like make sure you're wearing your protective clothing. If you do get stung, you kill that right away. It doesn't matter where it is, just kill it because you don't want that pheromone coming out to bring the other bees in. And you're gonna immediately like get that antihistamine and you get out of the situation. Make sure you're always carrying the smoke with you. Honestly, the weirdest thing is do not eat bananas when you go out because it's the same smell and that'll attract them to sting because they think that you're being attacked. That's a simple one. So, yeah.
This is completely anecdotal, but hay fever seems to be the common trend that I hear. I have hay fever and it seems like that's the ones that get severe.
Yeah, I mean, that's an allergic response, right? It's allergy to pollen or dust. So, yeah. And I mean, bees, work with pollen, so we're getting this sort of overlap. Yeah. I don't know who's next. Okay,
Sorry.
back, sorry.
This might be a dumb question, I don't know, but the mice that you injected with blood that was used to getting stung or whatever?
What was the blood or?
The IgE blood or something?
Yeah, yeah.
So are you saying that a blood transfusion from somebody that is immune could then desensitize somebody that has anaphylaxis?
Sounds like a silver bullet.
Yeah, the studies haven't been done. It sounds interesting. I mean, it's a possibility. I mean, we work with mice first because people tend to care less about mice than humans.
Yeah, because if you're allergic to peanuts and somebody else doesn't have a peanut allergy,
would that correlate over?
Just fix you.
Yeah. So the blood that was injected was blood that had the IgE specifically to the venom, sorry. So it was specific IgE to venom, so it was a little bit more specific rather than just regular blood. But yes, so the theory goes, okay, if this is working in mice, could be transferred over to humans. Now, the reason we work with mice is mice have a similar immune system to humans. Probably the most similar, opposed to primates themselves, like apes and chimpanzees and stuff. But, and they have a shorter life period, so everything you can do research really well with them. So, I mean, yeah, it's a theory. The theory is how do you test that? How do we get around an ethics committee saying, okay, let's inject you with someone else's blood and then test them?
Yeah, and how, did you inject, if I took 100 bee stings, would I then give the transfusion to my mom
After that?
immediately or
Yeah.
later on, or would that kill her?
Your blood, as long as you're the same type and everything, your blood probably wouldn't kill her, but I don't know if it would actually give her protection.
Okay.
That would be what's interesting. Would it give her protection? The mice study showed that, but does that mean it would work in humans too? That's a good study that could go out there. Right now, it's easier just to give minute amounts of venom and react and register that.
To pile on what Rial had said too, we find that when people work for us, if they don't get stung enough, they get that reaction.
Yeah.
But if they take a few every day, we actually tell them not to wear gloves and to try and not wear protective gear.
Unless,
If they go too long.
I'm saying if you have an anaphylaxis response.
Yes, yeah. If they have
Then you can.
anaphylaxis
Otherwise, yeah.
response, I wouldn't even let them on
Yeah.
the farm or in the VR.
People are stubborn though.
But yeah, no, my mom has anaphylaxis, and many beekeepers, wives or children, have had to do the desensitization.
That's actually how Brad and I got in contact with each other.
Yeah,
He was asking me
it's-
about that.
It's a huge problem,
Yeah.
so.
But it really is, it's that constant sort of desensitization of it. That might be what's the solution is here.
I've been working with bees for over 50 years, so I've been stung my share of times. But you didn't mention anything about what you should do if you got stung in the field.
Can't hear you, Al.
So, so what you're saying is if you get stung in the field, what do you do?
Yeah.
And you're having an allergic response?
If you got stung in the field,
And you have a really bad response?
the best thing I've been using for most years is black mud. It's got to be black mud. And you got to spit on it, and you just rub it on there. And 5 minutes later, I couldn't tell you where I got stung.
Yeah, you guys probably have better treatments than we do.
And even better than afterbite.
Pardon?
It's even better than afterbite.
Yeah. Well, I mean, and especially if like we're talking about where they get their pollen, the pollen's of course coming from the flowers are growing in the soil. I mean, maybe that's why there's something in the soil that negatively reacts to the toxin.
And I even used to carry a little pouch with dirt in it that was damp already.
It's a good idea.
And I would put a little bit of spit in there to get a little damper, and it worked even better.
There you go. Yep. That's awesome. I don't know who was next.
Yeah, there was research done, I don't know, in the 60s, 70s, there was a lot of money raised to address this problem for the bee industry, and I believe that research went on here in Manitoba for, and I forget the researcher's name, was it Dr. Day or David or something like that? And basically
I don't know about that one, but okay.
what that identified was that 1 in 3 of beekeeping family members was allergic to 1 in 25 of the general population.
Yeah.
And to address that, I guess what happened, and that happened in our family, is that if you came home with the venom on your coveralls, you made your children predisposed to later on when they became involved in the bee operation, they'd be allergic. That's what happened in our family. So I guess to get around all this, the suggestion was made to have your infants or your children get stung at an early age, like 2 or 3, and that would desensitize them when they did become older to work in the bee operations. So that research went on in, I believe, the 70s.
Yeah, I mean, the generally prevailing allergic response was, so we've had this like increase in peanut allergies, right? We've had this increase in just reacting to foods. So what they did literally for the late 90s, early 2000s was, oh, well, you know what? That means you shouldn't be eating them. Mothers shouldn't be eating when they're pregnant. Kids shouldn't have them when they're, under 5. No one should have peanut butter. Well, what's happened? It's gotten worse. Yeah. So literally, we've gone completely opposite in the allergy field, saying exposure, exposure, exposure. Get it in there. Make sure you're watching them to make sure nothing happens, and then you're able to travel. But get it in there, get it done, get it started. So that's, I mean, there you go, exactly that. That's get them in. But make sure you're always watching. You've got a way to pop right into the hospital if you need to. Yep.
Yeah, we lost a couple weeks ago. We had one of our foreign workers being exposed to some dust from full-blown allergic reaction, and phoned 911. And he said, "Well, wait there." And I told the lady on the phone that it's going to be like 45 minutes to an hour before the crew, the ambulance gets to their honey house, and he was already kind of calming down. His airways were fine, but if it was a full-blown allergic reaction, he would have been dead. And I should have got the name of the lady on the phone, but she doesn't realize in rural Manitoba it can be up to an hour.
Yeah.
And I'd like to see that addressed, because that could have been fatality at our premises.
And that's why they recommend that you have an epinephrine pen, an EpiPen on you, because there's that adrenaline shot that'll keep them until that ambulance gets there. That's the idea behind it. I mean, I wish I could build more hospitals in Manitoba, but that's not my field. Sorry. I agree with you.
Sorry guys, we're gonna have to cut it off there.
Thank you.